Good evening, everyone. My name is Dr. Zubair. Today we are going to discuss about the anemia. So let's begin it. What is anemia? It is reduction in circulating red blood cell mass. When the red blood cell mass is decreased, we call it the anemia. Another definition we have is it is defined as when hemoglobin is less than 13.5 gram per deciliter in males, and if it is less than 12.5 gram per deciliter in females. So normal hemoglobin level is 13.5 to 17.5 gram per deciliter in males and 12.5 to 16 gram per deciliter in females. So when HP level, if it is less than the normal range, we call it the anemia. There are many signs and symptoms of the anemia. Few I have written over here. It presents with the signs and symptoms of hypoxia, weakness, fatigue, and dyspnea, pale conjunctiva and skin, headache and lightheadedness, angina, especially with pre-existing coronary artery disease. These are few of the symptoms which our patient will have if he or she is suffering from the anemia. Classification, next topic we are going to discuss today, it is the classification of the anemia. We have the mean corpuscular volume, average volume of the RBC. Based upon that, we can classify anemia into three types. The normal mean corpuscular volume or average corpuscular volume, we have it is from 80 to 100 micrometer cube. So based upon the MCV, we have the following classification. The number one, microcytic anemia. Why we call it when the MCV, if it is less than 80 micrometer cube. Normocytic, when MCV it is equal to 80 to 100, normal MCV. And macrocytic when MCV if it is more than the 100 micrometer cube. So we have three types of anemia: microcytic, normocytic, and macrocytic. In all three types, we have different pathological conditions. Let's discuss the first one, the microcytic anemia. We call the anemia microcytic anemia when MCV if it is less than 80 micrometer cube. Microcytic anemia, they are due to decreased production of hemoglobin. And what will happen, RBC or red blood cell progenitor cells, from where the RBCs, from where you are getting the RBC in the bone marrow, they are large normally, and they normally divide multiple times to produce smaller mature cells, smaller RBC having the corpuscular volume 80 to 100 micrometer cube. Microcytosis can occur due to extra division, which is occurring actually to maintain hemoglobin concentration. Hemoglobin, as you know, that it is made up of heme and globin, and heme is composed of iron and protoporphyrin. So if a person is suffering from a condition, or if you have decreased amount of iron or porphyrin or globin chains, what will happen? He will have the microcytic anemia. So basic cause of microcytic anemia is the decreased production of hemoglobin, and which will cause the extra division to maintain the hemoglobin concentration, and components which are making up the hemoglobin, if there is the decrement in their concentration, a person will suffer from the microcytic anemia. Different conditions which are present in which are included in the microcytic anemia, I've listed them. First one, the most important one, iron deficiency anemia, then anemia of the chronic diseases, then sideroblastic anemia, and thalassemia. These are the conditions in which the microcytosis is occurring, and anemia occurring in them, we call that the microcytic anemia. Macrocytic anemia, name is suggesting big cells, or megaloblastic anemia. It is the anemia in which the mean corpuscular volume, if it is more than 100 micrometer cube, it is due to folate or vitamin B12 deficiency. We call that the megaloblastic anemia. The two main causes I have written, which are causing the megaloblastic anemia are the deficiency in the levels of vitamin B9 and vitamin B12. What is the function of vitamin B9 and B12? They are necessary for synthesis of DNA precursors from where the DNA is formed. So folate actually, or vitamin B9 in the serum, it circulates as methyl tetrahydrofolate. Removal of methyl group from this, it allows uh, for the parties of it allows the methyl TH from the methyl THF. If we remove the methyl group, the tetrahydrofolate part of the folic acid or folate, it will help in, or it will participate in the synthesis of DNA precursor, and that methyl group which was removed, it will be transferred to vitamin B12. We call that the cobalamin also. So that vitamin B12, it will transfer it to homocysteine, giving rise to the methionine. So if there is the decrement in the concentration of folate or vitamin B12, ultimately the DNA precursors will not be formed or will not be synthesized. Homocysteine, it is an amino acid. Impaired division will occur and enlargement of RBC precursors will occur, and this will give rise to a megaloblastic picture or big cells or macrocytic anemia. Impaired division of the granulocytic precursor, it will lead to hypersegmented neutrophils. Normally, there is no there you will never see the hypersegmented neutrophils. You will only see in case of the megaloblastic anemia. It is also seen in rapidly dividing cells, for example, the epithelial cells in the intestine. There are some other causes of macrocytic anemia in which there is the increased increased MCV, but without the megaloblastic changes. It includes the alcoholism, liver diseases, and some drugs, thyroid drugs. Third main uh, type of anemia, we call that the normocytic anemia, in which the MCV, or average corpuscular mean corpuscular volume, if it is in between the 80 to 100 micrometer cube. So normal sized RBC will be there. There are different causes. There are two main causes. It is either increased destruction of RBC. The cause is either the increased destruction of RBC, which is occurring peripherally, or there is the underproduction of the RBC. How you going to differentiate it? We have the reticulocyte count, which will help us to distinguish between these two etiologies or causes. Reticulocytes. What are reticulocytes? They are young red blood cells released from the bone marrow. They are identified on blood smear as large cells with Jewish cytoplasm. I have given a diagrammatic illustration of the reticulocyte. This is the reticulocyte. Normal count of reticulocyte, it is 1 to 2%. Now, as you know that red blood cell lifespan is 120 days. Each day, what is happening, 1 to 2% of RBCs, they are being removed from the circulation and they are replaced by the reticulocytes, which are young RBCs. So what will happen if a person, if he or she is suffering from the anemia, if if their marrow or bone marrow, if it is functioning properly, the reticulocyte count will be increased by more than 3% in case of anemia. However, it is sometimes, if it is falsely elevated in the anemia, it is measured as percentage of total RBC. Now, what is happening in case of anemia? There is already decrement in the total RBCs count. So, as the RBC count is less, so ultimately there will be the falsely elevation of the reticulocyte count, because they are depending upon the total RBC. So if the RBC amount is less, and even if the reticulocyte count is higher, that is why we are calling it the falsely elevation, because uh, RBCs, they are decreased in case of anemia, and ultimately the reticulocyte count, as it is depending upon the total number of RBCs, So RBCs over there, they will produce the reticulocytes count that are replacing their the destroyed RBC. It will be higher. However, however, this will be, however, it will be the, however, this elevation we call it the false elevation. So it is corrected by multiplying the reticulocyte count. How you going to count it, or how, it is actually corrected by multiplying reticulocyte count by hematocrit and dividing that by 45. Corrected count, if it is more than 3%, it will indicate the good marrow response and it will suggest the peripheral destruction. If the corrected count, if it is less than 3%, it will indicate the poor marrow response and it will suggest the underproduction. So what we have discussed right now, reticulocyte count, they are the young RBCs that actually are replacing the destroyed RBCs. So they are depending upon the total number of RBC. As in the anemia, the RBC count is less. However, we cannot correlate the anemia with the reticulocyte count as they are depending upon the count of RBC. So in the anemia, there will be the false elevation. The reason of this false elevation is, as RC, or reticulocyte count, it is depending upon the number of RBC. In the anemia, already there is the reduction of RBC. However, there will be no reduction in reticulocyte count as they are depending upon the RBC's count. So there will be the false elevation you are going to see in case of anemia. So how you're going to correct it, correct the count, you are going to multiply the reticulocyte count by hematocrit and dividing it to the 45. Hematocrit, what actually is the HCTR hematocrit? It is the proportion of RBC in the blood. So if after correction, if the count is more than 3%, it will indicate the good marrow response and it will suggest that there is the peripheral destruction going on. If the corrected count, if it is less than 3%, it will indicate the poor marrow response and it will suggest the underproduction. Now, what actually is happening in case of peripheral destruction? Peripheral RBC destruction, we can, or hemolysis, we have divided it into two types, extravascular and intravascular hemolysis. Both result in anemia with a good marrow response. Extravascular hemolysis involve RBC destruction by reticuloendothelial system. What is actually the reticuloendothelial system? It includes the macrophages of the spleen, liver, and lymph nodes. Intravascular hemolysis, it involves the destruction of RBC within the vessels. Now, different causes are there. The normocytic anemias with predominant extravascular hemolysis, it includes the hereditary spherocytosis, sickle cell anemia, and hemoglobin C. Anemia and microangiopathic hemolytic anemia and malaria. They are the causes